Good morning. Thank you. I'm delighted and honored to be here, and thank you for such a gracious introduction. Okay, so we've got a lot of material to go through. I'm going to go through the didactic stuff, which may be a little boring, but I think we've got to get the theoretical stuff under wraps, and I'll try to make it as smooth as possible. And then move from the theoretical underpinnings to eating disorder etiology, that is, issues that are behind causation, and then into some of the treatment models and how we use the treatment vis-a-vis the theory. And then kind of move into applying the theory and the treatment into real life and into real cases. And so essentially what I'd like to do is introduce to everyone using the same language, because this is what I talk about regularly with patients, is learning a language, learning an emotional language, so that what I do in a treatment setting with patients and families is basically what I teach families to do at home with their child, and so that it becomes a very comprehensive, and it's not a theoretical frame, but it is more a fluid frame. And so often when I speak with families and patients, my way of working is essentially what I say is I take off the white coat, so that I will explain to you what I'm thinking and why I'm thinking it at the time, and then try to frame what the patient is telling me from several theoretical models. Could it be this? Could it be this? Could it be this? Could it be this? And then the patient ultimately decides, and the family, what is it that resonates with them. And so I think in terms of eating disorder treatment, the more you know, the better it is. So on two levels. The more theoretical, then you can pull from inside and spin the patient in terms of many different ways of viewing her. And I'll use her, but I'm referring to her and him, and helping families as well to begin to look at their child in that child's particular way. So the other piece to understanding theory real well is that you can understand motivation. And that's what it is that we try to do. So what motivates an eating disorder? And we've been all over the map in terms of, we've had several camps, right? There was a gene camp for a while. There was the original camp. Eating disorders started, like the first case of it was somewhere in the 14th century, and it was linked to asceticism. And it was for young girls wanting to enter the convent. So the more perfect, the more pure, right? So it wasn't linked to body size and shape. It was linked to purity. To not restricting meant being an ability to be closer to God and to serve God through restriction. And then obviously we moved along that pendulum into the 20s in terms of standards of beauty, and then into the 60s and beyond. And then eating disorders have just exploded, right? And they are considered epidemic now. So I use that piece to kind of look at eating disorders more holistically. So we take the gene, which again, no gene yet has been found, and we look at certain other conditions, biological conditions, interpersonal conditions, intrapsychic conditions, and then familial and relational and environmental, and what's happening in the culture at the time to sort of understand the mechanisms behind an eating disorder. Okay, so I will go through these kind of major groups of theoretical models and just kind of succinctly explain what happens in each of them. All right, so many people have, a lot of the studies are showing that there are predispositions to anxiety and depression. Again, that no gene has been found that cause eating disorders. And across, when we look at the studies, we find that child upon child upon child, family member comes through their childhood and into adulthood with depression and or anxiety that appears to have been there since the very beginning. And so that we have certain predispositions towards specific personality types. I have some thoughts about that. Particularly when we look at, so we're looking at some inheritable traits like perfectionism. So again, is that inherited? And then to spin it from another model, is that necessarily inherited, or could that need to be perfect come from some other failure or some other condition that has led that person to go down the scale of the need to be perfect rather than the predisposition or the inheritable trait to be perfect. That regardless of what triggers the anxiety and or depression, that it does involve biochemical changes. We have seen on PET scans that it heats up in portions of the brain that are responsible for anxiety responses and for serotonin, particularly serotonin, and for neurotransmitter. So again, is it there before, or are the anxiety and depression conditions related to once the eating disorder sets in and the person is then their brain is responding to the nature of the eating disorder. Again, same thing with neurotransmitters. Are they intact? And so the eating disorder causes the whole brain system to go wonky because of lack of eating and lack of nutrition being provided to the brain. The dopamine receptors all screwy, so you can't get an accurate read on other neurotransmitters, more the calming neurotransmitters, because the person is engaged in more addictive behaviors. It becomes very, very confusing to tease out the chicken and egg. So we kind of accept that it is, although those of us in the analytic camp who tend to look at things more holistically, we really want to know why. Okay, so here's the big study, right, that came out, and here's the reason why genes cause eating disorders, and it was based on a twin study. But there was a very significant flaw. First of all, the twin study was done among a very, very small set of twins, and the condition that they had nothing to do with eating disorders, that caused a gene to mutate, and the response was an eating disorder. So it wasn't that it was a deliberate cause and effect, it was that there was a gene mutation that occurred in these very specific sets of twins. So we basically had to marginalize it as far as explaining, here's the proof that genes cause eating disorders. So it was, again, gene-specific, but to a medical condition that had really nothing to do with the development of an eating disorder. It was a byproduct of. So again, depression and anxiety, more identified. What we do with a biological model is that we tend not to look at, none of this matters, we tend to look at targeting the mood and targeting the thoughts and obsessional behavior. So it doesn't matter from a medication perspective from where the illness came. It matters how we treat it. So when we look at studies, longitudinal studies on the efficacy of medication, usually is a course between 6 months and 2 years where you'll trial somebody on, let's say, an SSRI, Prozac. And again, they're very specific to the nature of the eating disorder. So you might use Prozac for a patient with bulimia, but you might be able to use Wellbutrin for a patient with anorexia because the Wellbutrin for patients with bulimia could cause seizures. So you've got to be very, very detailed and specific. However, when we trial these patients for 6 months to 2 years on the medication and we withdraw the medication, titrate it down over a period of time, what we find is 50% of those patients are going to require the medication again versus 50% are not. So, okay, does that lean us toward thinking perhaps more biological predisposition at this point, or is there some other variable that's intervening? The good news is that no one who prescribes medication ever thinks, or no one ought to, ever thinks that medication alone is sufficient in treating eating disorders. So here's the way it works. So if you're treating, and somebody's on medication, and you begin to deal with the psychological as to what, so that their mood is elevated and the anxiety is decreased, and so you can get them to a different baseline, and treat what's going on in their life from whichever theoretical model you approach it with, and then remove the medication. Again, you will see. So what has caused that? Is it because 50% of those people, again, are in the group of having a predisposition, so they're going to lean back toward the medication anyway? Have they improved because they've addressed the psychological issues? And so all these things matter, and they're very idiosyncratic. So you can't, the bottom line being that you can't say that for every patient that this is the way to go. You really have to get to know your patient and to sort of tease out from where it may come. And again, some people, it does not matter. Except the depression is lifted, the anxiety has come down, and it's better. All right, so now we get into, I'm trained analytically. It's the sort of the lifeblood of how I practice and live, sometimes to the chagrin of those who love me, but it helps to explain, because again, the feeling is the more you know, the more you can understand, and the more you can therefore be in charge of how you respond. Knowing what drives your bus enables you to make very conscious decisions. So Freud, for those of you who do not know, who's seen on the one hand as the father of psychoanalysis, and on the other hand is some kook. There was a lot that Freud said. There's a wonderful book by John Stollerow called Faces in the Clouds, and he kind of looks at Freud, Jung, and I think it's, I forget, Rank maybe, and he looks at the reasoning behind why Freud created his theories. And of course, his mother is in the center of the book. But what Freud postulated, which makes a whole lot of sense, is that inside all of us are our drives, sexual and aggressive drives, and we spend the rest of our lives trying to defend against that. So in that very basic model about being primitive beings, which we are, we have the higher brain and the ability to socialize that brain to act in a socially appropriate way. But the drives are always there. And so that we look for ways, so said Freud early on, although he moved later into relationship theory. Early on, Freud said that we are motivated by these sexual and aggressive drives, and therefore we need people in our life to gratify those drives. So we're basically using people to get those drives met. That the treatment, well, what does psychoanalysis do? You lay on the couch 4 times a week, and what good does that? You come out more neurotic, and how is anything, solved? Psychoanalysis has said that they've never claimed to cure the symptom. Therefore, in treating eating disorders, it helps fuel our understanding tremendously, but we have to then apply other theories, and I'll get to that in a little bit. But from a very psychoanalytic model, that treatment cure comes through interpretation and the development of insight. Therefore, the more you know, the more you are able to consciously go out into the world and make decisions, the easier it is. If you know your stuff, you know what's driving you, you can easily then distinguish between, okay, this is me, or it makes it much more clear, or this is coming from the other person. And that's the stuff in therapy. Click, 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 click. Okay, why is this patient generating these feelings in me? Or because they're triggering something in me that is making me feel angry, happy, sad, competitive. And if you know what that is and you're still left with, I'm still having those feelings, then you can twist it back to, okay, why is this patient conveying this to me? What is it that they're needing from me? What is it that they're trying to tell me? And that's the purity in the relationship, as best as it's going to get, where you can then actually read you versus them. And these are the things that we teach, again, to family members. Do you know what's going on inside of you so that you can know what are your responses and feelings and what are connected to and what are your child's responses and feelings? Separation, right? That's a whole other kettle of theoretical fish. Okay, so actually, out of Freud initially came all these British people, and they started to move toward the British school. And others, and they started to move toward, doesn't make sense. Okay, so if all we are driven by sexual and aggressive drives, how do you explain love? How do you explain connectedness, relatedness? And what are the other manifestations of need and expression? So in relations to eating disorders, that the symptoms of an eating disorder really serve to be used as kind of a metaphor, as a parallel process to how it is we are feeling in life in general. And so Hilda Brooke, who got also a lot of, because she was very mother-blaming, that that the symptoms mask a sense of ineffectiveness and a lack of autonomy, right? So think about it symptomatically. Person with an eating disorder really feels powerless inside, even though it appears to everybody else that she's in complete control and she's controlling the family and, and so on. And there's a lack of autonomy because she cannot separate from that eating disorder. And so what is the purpose that that serves? Why does she need to behave in that way? What initiated that response so that she would need the eating disorder in which to convey what about her life? Maudsley, that the eating disorder is impeding separation and individuation, keeps adulthood from happening, keeps the body from changing, right? You don't eat, you shut down, estrogen stops, the whole puberty process terminates, and a child remains, or an adolescent remains, or an adult remains prepubescent. Therefore, they do not have to take on any of adolescent tasks, any of the sexual development tasks. They can remain a child. But for what purpose? Again, that's unique and specific to the patient that's in front of you. Here we move into my favorite theory, which is object relations and attachment theory. John Bowlby, a British psychoanalyst, 1906, and Mary Ainsworth, who was 6 years his junior, who was his protege, stopped at the point of, he accepted Freud's principles of internal drive. But he also said there's something more here. It's not only that we seek gratification of those drives. It's not only that we seek love and comfort. It's also observable. How are we treated from the outside, from the external world, internally, that shape and respond to our sense of selves? So he observed families, parents, children in foster care, children in asylums back in the day, and saw that they had all these patterns of disassociation and inability to be soothed and be comforted. And when an adult walked into the room, they would cry and scream more, or they would shut down and pay no difference, pay no mind. So from an eating disorder perspective, we see his work as seminal, because it is the development of attachment. And what is that representation of attachment? So patients stay attached to the eating disorder. What is it that they are really seeking to attach to? In the absence of real fundamental closeness and bonding and security, they use the eating disorder as the relationship of choice. They use the eating disorder as the expression of pain, and there is the metaphor. And so on the one hand, it is a way to soothe. On the other hand, it is a way to express. And so when we start to factor in and move into, looking at, okay, click, 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 we've got maybe the biological stuff happening here, click, 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 okay, there's a learned pattern of anxiety and depression. Maybe it's not biological. Maybe mama, feels anxious all the time, and so the child learns to be anxious because that's the pattern of how mom relates, versus that it's coming from a biological predisposition. So we bring those in, and we start to then bring in, okay, what else are we observing here? What are we observing about the relationships? How does all this play together? And move us further away from just the internal mechanisms into the social world, into the interpersonal world, into the fundamental relationship world. So as I mentioned, that the food in the body is dependent upon a substitute for relationships. So it is the expression of conflict, right? People can see it. Patient, sibling, family member, they're on fire, right? The family sees it, that they're in such pain and despair, and it's a statement of something's wrong here. And it is also the expression in the same breath, right? So it controls on the one hand, it taunts the family, it's cruel to the family, it's cruel to the patients, it's an assault on the body. On the other hand, it is an adaptation. It is in the absence of anything real, I will turn to the symptom in order to try and feel better. And that is the contradiction, right? So let me tell you let me show you how angry I am and how bad I feel. On the other hand, do not take this away from me because I need it to provide comfort for me. And so when we start to look into treatment, you say to yourself, why would any patient want to step into eating? Because that's going to signal for them complete loss of control. Why would you want me to eat when I am able to manage an internal world that feels so chaotic to me? And eating is like taking like shooting heroin, right? That's how it feels. So as I move into treatment in a little bit, we start to look at relationships, and we start to explain to families and to patients about healing coming through not the symptom, right? We need to do some of that, and we'll talk about CBT, DBT, and FBT, but through that process of healing relationships, developing an authentic self. Again, so we look back at the Freudian thing. Okay, the authentic self means an honest self, means a person who's willing to be rigorously honest and say exactly what's going on with them versus what's passively, aggressively somehow expressing it. So we take all this and we put it together and we start to use it in the room with patients and families and in the room with our patients together. And so again, so on the one hand, Freud would look at that as transference, right? So the patient is starting to see you as that family member in their life. And from an object relations perspective, okay, so now trust is starting to build and attachment is starting to form. And so, you can see, and then you get, again, the cues from the patient as to what it is that they are really conveying and what it is that they need from you. And in my opinion, you cannot do that with having very limited theoretical frame. You need to for the therapists in the room, and I'm sure, learning about as many theoretical models as you can without poo-pooing any of them, I think can only enrich and enliven the treatment. Again, patient is attached to the eating disorder. So back to the tenets of attachment theory. Bowlby, Ainsworth came up with, which we are finally using today. There are scales of attachment, and it's like sort of the aha moment, like, oh, you think that these things matter? I say often that in a culture that we live, what we try to do is fix rather than feel. What we think that we can replace through coming up with all kinds of ways to kind of make things better rather than to experience things better has caused us a huge disservice, right? How many of you, walking down the streets of Manhattan, and there's a line of girls, maybe, they're like 12 years old, maybe there are 5 of them, and they're just walking down Broadway, and they're texting, right, as they're walking. And then one of my young patients said to me, they were probably texting to each other. And it blew my mind. The absence of relationship now. We have found so many ways to disengage. And when we look at addictive models, and we look at, the internet, and we look at porn, and we look at the, we look at the addiction to so many things. We are looking to disengage ourselves, not only from an experiential world, but from a relational world. And it's becoming easier and easier and easier. Social anxiety is way up. Someone just told me recently from a major university of like 18,000 students, and on any given day, they have 250 students walking into that healthcare, and she couldn't give specifics, but she said the amount of patients coming in for anxiety is extraordinary. So what is all this? And the number of eating disorders being so epidemic. What is this? Gene, biology? I don't think so. You can't suddenly just say that all these biological conditions have emerged. There is something else that is driving our response to be in a very shut down and very unexposed way, but manifested through profound anxiety. Freud said that if you do not feel things in a pure state, the emotion does not go away. And Anna Freud, his daughter created a whole theory of ego-psychology where we come up with defenses to really protect ultimately from those pure states. And so in other words, if you do not feel it, if you do not understand the motivation, the psyche won't let you get away with it. So we build then, from an analytic perspective, we build then walls. One of the walls is depression. It's all turned inward. Anxiety. It increases because something's going on inside of us that we can't identify, and therefore it has to be manifested. Then we move to symptoms, right? We've got the whole array of symptoms: shopping, eating disorders, drugs, alcohol, porn, sex, and we find another way out through an addictive way to try and soothe what we cannot soothe experientially and internally because we have lost our way. And then beyond that, we get into even other kinds of behaviors. If those devices don't work, again, we find other sources, more aggressive sources, more suicidal kinds of ways to convey what needs to ultimately be conveyed, because we cannot, despite technology, we cannot escape our humanity. Although, AI will eventually. And replicate ourselves to be even a better self. And, from a medical perspective, that's always good, but from a social perspective, that's not so good. All right, so interpersonal psychotherapy, which is originally prescribed for a lot of eating disorders, it's not looking at symptoms, it's looking at the interactions and what's going on in the person's life, and it began to address the relational world, the parallel world between symptoms, between eating disorder behavior, and between what's going on in the person's real life. Disengaged, because it was time limited, it has usefulness, it doesn't really delve into cause. It's based more on behavior, but it's based on the behavior of, okay, I feel lonely, rather than I want to eat. It's, okay, what's underneath I want to eat? Okay, I feel lonely. Okay, so let's do something about that. It has its usefulness and application in the treatment modalities, but it does not explain from where does that loneliness come, and how does food address that? What is the purpose, and what types of food are you eating to deal with the loneliness? And again, from a more analytic perspective, we look at if somebody's choosing ice cream, right? What does that mean? If somebody is throwing up ice cream versus eating pizza and throwing up, and the cutting in the back of the throat from the crust of the pizza is really what the desired effect is. So that all these things become relevant when there's time and ability to pay attention. And clearly, when you're starting to treat a patient with an eating disorder who's really sick, you can't do any of this, right? You've got to get them up to a baseline weight because their brain is not functioning. And that we'll talk about with FBT and things in a minute. All right, so just to put in two other, or a few more theories. So the feminist theory in terms of eating disorders, that women will always be nurturers and caretakers. Is that, for many women's roles, is that comfortable and normal? Absolutely, hands down. But the restrictions that come in response to that, therefore, if I am that, therefore I cannot be this. And this is the conundrum for most women, particularly when the woman is working outside of the home or working in home and doing other things besides child. The ability to, on the one hand, try to do it all and to do it all successfully are two different things, right? And so, and what emerges then for women are tremendous guilt and trying to overcompensate, and therefore can an eating disorder emerge then? Hands down, absolutely, because it is a way to quietly solve a problem that a woman feels she ought not have in the first place, which is the ambivalence or the guilt for not being enough or doing enough. So from a feminist psychoanalytic perspective, which it really looks more at the relationship between the mother and child, father and child, in terms of what are those gender roles that were expected of that child. So if mom is the nurturer and the stay-at-home, is the expectation for that child to be similarly? Is that child, therefore, because they cannot allow other appetites to emerge, they stay with the appetite of food in order to express what they feel guilty or cannot express in other ways, intangible appetites, success, power, sex. We allow that clearly, again, from a feminist psychoanalytic perspective, we allow that in a very male-dominated world, but we do not allow these very normal and typical reactions and wants and desires in women. And sometimes we blame it on, well, men have more testosterone. Yes, happily so, but that the emotions, we are emotionally cut the same. We have different genetics and different biologies and different things that make us happy. Yes, will many boys given the choice without, if you can weed out any of the variables and the preconditioning, so you put a little toddler in with trucks and toddler boy in with trucks and dolls, often they will go toward the truck. And again, you've got to weed out how much preconditioning was done before. But these things are wonderful and normal. This is what makes men men and women women. But when we talk about brains, when we talk about hungers, when we talk about emotions, these are the things from a feminist psychoanalytic perspective that get very tripped up, because those things are on par. All right, now we get into the hodgepodge of family therapies. I'm going to talk about FBT, family-based treatment, Maudsley, at the end. I want to just go through. So the systems theory, and you see, like, qualitatively, there are very few, like, subtle differences in terms of which school you're following. So from a structural, from Minuchin, those of you who remember reading Minuchin, that simply the symptom bearer is the patient with the eating disorder. She's kind of expressing that there's a problem in the family. She's ringing the bell. And so from that, when you're dealing with the family there, it's beautiful because you can say, okay, everybody here owns the symptom. It's not just her. She's the one who is expressing it for the entire family. From Milan, that the eating disorder is a homeostatic mechanism. Yeah, everything stays focused on that eating disorder, and therefore nothing else gets addressed. So it works. It works as a wonderful container. Strategic, that the symptoms are illnesses and they are outside the family, right? So they are seen, you're starting to see a little bit more shift into a Maudsley kind of thinking, and that the illness is truly a burden on the family. And so it's exogenous, outside, coming in. Maudsley, all right, so here's where the split happens. I think, sometimes, I've been, because of my work working with families and trying to bridge this gap, you're either in the camp of parent blaming, right, or it's all genetics. Again, it is neither this nor that, likelihood not genes, but likelihood all the biological and everything kind of thrown together. If we keep things separate, how much better are we? When I see in my professional circles and the research that is just, to just get success because you are shoving 4,000 calories into a patient a day to be able to say that that patient did well in the treatment study is exactly, it's antithetical to everything that we try to do in terms of how we try to help our patients recover. It is the same thing when we take an either or. That yes, it is possible that your child may have developed an eating disorder because of something completely exogenous, that child had a sudden death in the family, that there was some kind of traumatic event, that there is trauma that under a very healthy, attached, functioning, predisposition, non-existing family, that something bad happens to that kid, and that kid latches onto an eating disorder to solve their problem and to try and distract and to try to make sense of it, absolutely. But what we have hopefully, and what I hope I can leave you with today, is that it's all integrated. And if you have the courage to face what it is that may be for your patient in front of you, for your child, for yourself, to really examine, well, what is this? And for therapists, sometimes it's the hardest thing to say, you know what, either I don't know enough, right, and I can't explain my patient, or when you are trying to force your patient into some theoretical model that, that because it's got efficacy here, and you're pushing in that direction, how much more authentic are you being? And how can you therefore then expect that authenticity in your patient? To be able to say, gee, I don't know. Let me tell you what I'm thinking. I'm thinking about it this way, this way, this way, this way. And the patient says, no. And I say, okay, so, help me understand this. We've got to still figure this out together. The more we can step out of our ways and acknowledge that we don't know, the greater you're going to be as a therapist, the more understanding your child is going to be, the more, as I say very regularly, it is not so much the mistakes we make, it is the repair of the mistakes. It is that person, that patient, that child, that parent can count on you, that when, I know that when Judy's wrong, she'll say she's wrong. And so I need to trust now when she's pointing something out to me that maybe it has some clout, because I can count on her to tell me when she knows that she's in the mix of somehow making the problem. And that's what we look for across the board. That is the common ground among patients, therapists, family members. Okay, so let me just, one quick thing on Maudsley. So it's done in 3 ways. You stabilize a patient, family takes over, from the old eating disorder school thinking, it's like, how can you take the control away from the patient? The family, it's more control. It works. It works particularly for younger adolescents. The refeed is faster. In a longitudinal studies, when we look at family systems theory versus Maudsley, in about a year out, there is no difference in terms of weight gain. That it is about the same. But Maudsley model works quicker to get the weight on because the family is in control and oftentimes the patient needs. And you as the therapist, if you are working in that model, to say to the patient, do you trust me enough to say, your parents need to take over here, and we need to let them do that. And let's talk about how you feel by letting them do that. But it's about letting go and trusting that in the end, this is all going to be good. And so Maudsley is very well used. The second phase is letting that child regain the control again over some of their tasks and some of their eating. And the third phase then starts to look at some of the developmental cycles of adolescence and anything that's going on in the family, but it's downplayed. And that's the part that, for me, I have the more difficult struggle, because I think that part is necessary. Not necessary for all patients. So there will be patients who I see who get to a weight, they're functioning better, their mood is better, their medication, they've been given medication because they need it, titrated down, titrated up, and they're better and they want to leave. I don't care. I don't want to know what, okay, great, gone, good. And is that recovery? Hands down, absolutely. Is recovery that a patient can't ever in their life keep chocolate cake in their refrigerator because they know they're going to binge and purge on it? Yep, that's recovery too. So we start to define things in very different ways. One of the classic ways in treatment, that how we have always gone about treating eating disorders, is CBT, right? Prefrontal cortex, judgment, reasoning, okay, shifting some of the old tapes out, new tapes in, thought stopping, perception. How can this be? How can it be if the scale says this, how can you, insist that you are fat? It does not work to look at where that came from. CBT does not do that. So it's changing the thinking, right, and doing behavioral changes. And one must do this, no matter what theoretical framework. Again, analysis never claimed to cure the symptom. So you've got to use other models, other ways to help your patient get well. Even though you don't ascribe to a theoretical cognitive behavioral theory, you certainly can use the treatment in conjunction with other forms of theoretical orientations. And again, it's focused on the very present and future and remains extremely problem focused, which is very good, because you're really trying to help patients in the throes of an eating disorder to get real and to deal with life on life terms in a very concrete and realistic way. All right, DBT, wonderful, because it incorporates mindfulness, it incorporates exercises, it's done in a group. And what do many eating disorder patients have problems with is social interactions and listening to other people, making time for other people. So if I were running a DBT group, I'm not qualified to do DBT. I have an understanding of the theory, but I couldn't do it. But if I were running watching and doing a DBT group, watching it more, I would be listening for, but okay, so like, but she said that likely because, that was a very competitive thing too. And if I were running a psychodynamic group, I would say, okay, so tell me how you're feeling right now. What just happened there? DBT does none of that, really. It uses that momentum to just make the changes, let it go. Find ways, mindful ways to reconnect internally to what your purpose is, to what that authentic self is. In a group way, so everybody is a cohesive and working together and working on their different problems, but the dynamic interaction is not relevant. Useful, particularly some of those meditation is always great. centering, finding some way to think internally, whether you do it because you're analyzed, and so you can stop yourself and say, what's going on now, or meditation because you can internally think and feel and release and let go. Basically, you're in a state of emotional dysregulation, not like, okay, so where did that, why did you start like crying at the drop of the hat? You're in emotional dysregulation, let's handle it. Versus, again, an analytic perspective would say, well, where's the sadness coming from? From an ego psych perspective, well, gee, that's a defense. It's not really sadness that you're feeling, it's really anger that's defense. So, again, it depends on the model. Substance use theory, again, a biological predisposition to addiction, nothing you can do, born with it, this is the way it is. It only looks at the causes of eating disorders. There's a cultural emphasis on body image because it's in the culture, it's attached to, right? And again, let me just say this about why the proliferation of eating disorders. If eating disorders were biologically based or solely culturally based, it's the proliferation, because the culture changes, and yet eating disorders increase. So do those people who somehow fit into the culture in the 1990s and suddenly don't fit into the culture in 2010 have eating disorders? Yes, even though during the course of the 1990s they still have an eating disorder and they fit culturally into the cultural ideal of beauty. So it's being driven from something else. It's just, again, we manifest by saying, if I could be that, if I can do that, if I can be it, I will feel okay internally. And it's easy and it works, just like anything, any kind of quick fix works for a very short period of time. Substance abuse disorders are up in 55% with patients with bulimia and 23% with anorexia, and you can figure out why. Anorexia more inhibited, and so they're not likely going to drink and kind of let their guard down. Patients with bulimia often, because of the nature of bulimia, which is it's more expressive, more explosive, more unregulated, uncontrolled eating and then throwing up, it has a higher link to alcohol use. And it is patients who binge report that while drinking makes them more relaxed so that they can purge. And in conjunction with eating disorders, what we have to listen for most are alcohol and stimulants. And you can understand why patients who have anorexia and the prescribing doc is not aware of the anorexia, and the patient says, well, I have ADHD, and they're getting Ritalin. What does Ritalin do? It shuts down the appetite. And so this is the reason why I'm not eating, is because of the Ritalin, right? So it's adaptive. The patient is really, truly, without judgment, trying to adapt. And I hope I get some time to talk about manipulation and why manipulation is necessary, why patients manipulate, and to try to maintain a compassionate and empathic understanding of that rather than a judgment. Sometimes it's very hard because it's extremely provocative. Okay. So some of these things I have gone through already. So we have the theories, and then we have the treatment that are derived from the psychological theories, and they don't always go together. You can have two different ones, coming from one theoretical perspective, but applying treatment that is very different than the theoretical understanding. All right, so psychoanalytic treatment. So again, we're looking at motivations, vulnerabilities. This is psychoanalytic. Knowledge is power. Knowing unconscious enables choice. Use of transference, right? Patient who projects onto you that you are their mother, and I'll demonstrate that in the case of Johanna, where it was beautifully done. And so that the therapist does not take the bait, but uses it rather as a means of interpretation. Very easy to do in a clinical setting if you are aware of what's driving your own bus. And sometimes I get this, I don't understand. If you can do that at work, why can't you do that at home, right? Fortunately, we ought not to, and it's good that we don't. It is highly provocative sometimes in treating patients with eating disorders because you're feeling so, gone after and maligned and misunderstood, and the patient, and you just have to take the step back. And this is what we have to help family members do, not take the bait. And it's really hard, or for the patients not to take the bait, or for the therapist not to take the bait. And again, that's where we start to speak the same language. All right, so again, CBT treatment, you see what it is. It's symptom reduction, it's behavioral, it's coping skills, it's all those things in the here and now that we have to use every day when we go out into the world, right? We do these things in a natural way. You harness them for patients with eating disorders to use them with their symptoms. Different, just a therapeutic alliance. We're in this together. It's not, you project onto me some of your fantasies of who you think I am. We don't use it. We translate it in a very different way. Okay, so you're telling me you're feeling this. Okay, so let's use that. What do you do when you have those feelings? Not tell me more about why you're feeling about me that way. Maudsley, again, there's the three states. Patients must be medically stable. I can't say that enough. You do not have medical stability, you have nothing to work with. You cannot prescribe medication. The medication at best has no efficacy. At worst, it causes further brain distortions, and you don't ever want to do that. Types of medications are very, very important, and that needs to be teased out by a psychiatrist comfortable with the treatment of eating disorders. There is no medication that specifically is used for the purpose of treating eating disorders. Okay, so again, you're normalizing the way. This is from the family systems, the ones that I meant before. And again, no significance between SBT and FBT, systems-based family treatment and Maudsley. Okay, mood stabilizing. Those are the ones, Lamictal, Depakote, that was going to slow a patient down. This is where, again, competent prescribing and where there is no manipulative intent by the physician, because you're taking those higher power drugs. It's going to stimulate appetite in patients. It's going to keep weight on, and it's very, very scary. And if you're going to use those drugs because they are medically or psychiatrically efficacious, you need to explain that to the patient as to what's going to happen, because again, you're trying to minimize. You're trying to say, trust me. You want me to trust you? You're going to have me gain weight? Yes. Addiction model, again, because of the community support, works well for some patients. We have to be very careful in terms of, from an addiction model, abstinence. I do not believe in the gray sheets. As Janet said earlier, diets don't work. That when you start restricting and saying that white flour, white sugar, anything white you don't eat, is just, again, there's no good or bad feelings. There are no good or bad foods. And this is, this is somewhat against that model, but there are some really good 12-step groups that form that don't ascribe to that they're really about support. They're really about having somebody there on the other line where you can call at any time or during a specific time and say, I'm feeling like I want to eat the cake and throw it up, and truly have someone say, take that cake, turn the hot water on, run it, pour Drano on it, pour whatever on a bleach on it, and make it unsafe and get rid of it. And that is the beauty, because you're accomplishing so many things there. You're letting in someone to help you, right? Big deal for patients with eating disorders. It is so impossible because food has been so reliable. And you're also concretely doing something to shift. And some of the behavioral things we do, with patients sometimes are like, we ask them to plan a binge, right? So where you're eating 5,000 calories at a binge, we say, can you plan a 3,000 calorie binge? Can you set aside one night and put 3,000 calories in front of you instead of 5, and let's see what happens. The only thing I want you to do differently besides that number, if you can, is wait 5 minutes before you start binging and ask yourself, how am I feeling? What's going on inside of me now at this moment that has nothing to do with food? And again, the real work is getting away from the food and seeing the food as a symptom and or the metaphor. The piece about making amends to others and offering help, a little tricky. Sometimes that's appropriate, sometimes not. Sometimes patients with eating disorders want to, because they feel so guilty for taking, right? The only way they can take is through food. They feel compelled to always help. And so you have to be careful about your audience and know that, is this good for my patient? To say, look, you don't have to be a sponsor to somebody else. You may never, maybe down the road you can. But for now, this is about you taking what it feels like to ingest food that is emotional food, that is not, and that has nothing to do with you having to give. That the way that you will give is to live by example and let other people see that, and that, within this model. And then you just have to be careful about making sure that a patient is able to find what they need within a 12-step model. Okay, so now we get to the more fun stuff of all that application of theory and how it works in a case. So what I'd like to do, using the case of Johanna, and I'm going to read it because I think it will be, you don't have to read it with me, you can just kind of, absorb it. All right, so here we are all together, right? Now trying to make sense of a case for those of us as therapists, for family members, for patients, to try to use this all together that, again, we are learning one way to be. So Johanna. Sometimes trust issues are hidden, and it takes some digging to expose them. Johanna was 12 when her pediatrician referred her to me for an eating disorder evaluation. She had been recently discharged from the hospital after treatment for complications due to her low weight. The hospitalization was medical, not psychiatric, and was intended to stabilize her and help her restore her weight. When she was admitted, Johanna's pulse was very low at 42 beats per minute, and she was severely dehydrated. Her parents were devastated and distraught over their daughter's diagnosis of anorexia nervosa and terrified by how quickly she slipped into a medically critical state. When I first met Johanna, she showed no outward expression of emotion, and she appeared to be in her own world. What Johanna didn't say was instead conveyed through her bizarre rituals and behaviors. Her parents reported that she once cut her long wavy hair, on only one side, and it took them an entire weekend to convince her to cut the other side before she returned to school. Again, there's implications in that. She washed her hands and face at least 5 times daily and wouldn't leave her bedroom until her stuffed animals and other possessions were lined up perfectly on her shelves. Johanna's compulsive behaviors both infuriated and frightened her parents. They would only understand later that the perfectly lined up animals were metaphors for Johanna's wish deep down to be perfect for them and herself, even though she outwardly appeared so oppositional. During the course of her treatment, it was revealed that her hand and face washing were attempts to wash away all that she felt dirty and shameful about herself and her provocative behavior. This came out later in treatment, and she was able very clearly to articulate it and define it. While her obsessive rituals and eating disorder could be interpreted as the onset of serious mental illness, I didn't see them that way. Johanna's behaviors weren't arbitrary or out of her control. Rather, I felt that they were deliberate and controllable, as if exhibited for a purpose. And so again, the experiencing the patient and the thinking, because it's so easy to label, right? OCD, autism, on the spectrum, if you don't know until you know. And so that's the piece that takes time, and that's the developmental piece with families as well, that takes time. You cannot say, this is what's happening for my child. Over time you can, until you listen and respond and say, this is what's happening for my child, because this is what the child is conveying. And then, of course, we have to talk about boundaries and things like that, which kind of disrupts that a little, but it would take some time to test my thinking. Johanna did not trust me in our early sessions. During the first 5 months of therapy, she continually tested the appropriate limitations set by her parents. I remained focused on making sure that Johanna was not a danger to herself, but I also modeled the necessary ingredients for healing and recovery. During one of our family sessions early in treatment, Johanna's mother expressed her exasperation and terror. This is her mother. She keeps doing things that are incredibly provocative, and she knows that it infuriates us. The other day, she was outside in the dead of winter in shorts and a t-shirt. It was freezing weather. My husband went out on the neighborhood looking for her, and we couldn't find her until way after dark. We were frantic. We thought she had passed out and was lying somewhere in the snow. I was horrified by the story and reflected back my feelings of deep concern to the parents. I was planting seeds of empathy in them. While the whole family needed to trust me, it was Johanna, most of all, who needed to be convinced that I was safe. How dreadful for Johanna that she would do that to herself, I replied, and how sad that this hurtful behavior is acceptable to her. I ask you to think about why she might have done this. To get us angry, her father replied. Yes, that's true, I responded. But isn't Johanna also telling you through these behaviors how incredibly bad she feels about herself? Can you put yourself in her shoes for a moment and think about how bad she must feel to treat herself in this way? Though Johanna's parents weren't yet ready to fully comprehend and accept the amount of pain she was in, when I asked this question, I could see the dawn of understanding in their eyes, as if, for the first time, they were beginning to see the problem from their daughter's perspective. My mistakes. The truth is that Johanna was not an easy case. Her behavior was quite extreme and worrisome, and Johanna herself was very bright and very mistrustful. She never missed a single verbal or nonverbal gesture on my part. She sucked up all the interactions in the room and carefully evaluated each and every one. At times, I would glance over to see her eyebrows crinkle as she processed everything that came her way. She was carefully evaluating me during those first 5 months, not yet ready to dip her toe into the pool of trust. During most of our individual and family sessions, Johanna refused to sit. She paced the entire room. One might assume she kept moving to burn off calories, right? That's the typical. The kid is bouncing up and down. The therapist automatically assumes that this kid is looking to, to burn calories. A typical eating disorder behavior. But I interpreted this behavior as her inability to tolerate being part of her family. The closeness was too much for her to bear. It was also a sign of her emotional agitation, her inability to be comfortable in her own skin, to be comforted. Last but certainly not least, Johanna was trying to infuriate her parents and me. It's not easy to conduct family therapy when one person is walking about the room. At times, I felt like I was a performer in a 3-ring circus. So much anxiety and so many messages being communicated in both verbal and nonverbal ways were often overwhelming for me. I found myself drained after some of the sessions. Johanna was testing whether I could be trusted. Could I tolerate her provocative behavior by neither approving it nor criticizing it? Eventually, I decided to confront her behavior a little, to test the waters by asking about it after the fact, rather than confront her when she was actively walking around my office. It was not that I had a particular feeling that the timing was right. It was more like we had reached a plateau and I needed to try something different. During one session alone with Johanna, I decided to take the plunge. Johanna, can you control how frequently you wash your hands and face? And is it that you cannot sit down or will not sit down during our sessions? Yes, and will not, she replied with a smirk on her face. We both knew her response was an enormous turning point. My relationship with Johanna had been evolving over time. I began telling her in a playful way that I had a feeling she knew exactly what she was doing and that she had to feel both good and bad about the power her behavior gave her. She knew that I knew, and this was a good thing. It relieved her, made her feel safe that someone might understand what she was going through. Not long after this encounter, Johanna arrived at my office in a particularly angry state. She had regressed to a point I hadn't seen in months. She refused to speak, frequently rolled her eyes, and mimicked how I sat in my chair and held my hands. Well, you know what that's like. Her parents could barely contain their anger and frustration. After a few months of working on eating goals with a nutritionist, Johanna was once again restricting her eating. Her blatant provocation during the session left her parents feeling helpless and infuriated. At one point, I glanced over at Johanna, and she appeared indifferent to her parents' diatribe. I felt frustrated and worn down by her behavior. It seemed like we're back at the beginning again. My frustration showed in my expression as I grimaced slightly, and I mean grimaced slightly. Almost immediately, I knew I had made a mistake. That nanosecond, right? With patients, it doesn't take a second. It's a nanosecond. They don't miss it. My reaction felt felt like a ton of bricks on Johanna. I knew this because it was a moment, less than a second, where I noticed Johanna's face drop, right? There was the authentic moment, okay? So when we start to talk more about getting your pay, that's it. We all feel it, right? And let me just digress for a moment on this point. We all feel it. That we know what we're feeling, and somehow then at that moment we change it into something else. And uncovering why is the work at hand. We do it the same way with eating, right? The metaphoric process. When we teach patients to read, you have that moment of healthy fullness. Okay, full, good, right? We ignore the internal cues. Patients with eating disorders ignore their internal cues, both feeding-wise and emotional-wise. That, when I saw the drop, it was an injury. It was a narcissistic injury to her. I had hurt her. But her defenses kicked in very, very quickly. And then she quickly resorted to behaving even more provocatively. So there's her defense, right? I'll get you. I'll show you. I'm so hurt. I'm going to use aggression as a defense against my hurt, right? Sometimes aggression is aggression. Somebody, deliberately does something to hurt you. Have an aggressive response is appropriate, but when aggression is used as a mask for sadness, for hurt, for psychological injury, it is very difficult to tease through that and to find the empathy in order to interpret it into what it really may mean. The issue at that hand between Johanna and me was trust. I felt I had breached it with my facial expression. Johanna knew she had gotten to me. Okay, good and bad thing, right? So that when using this with the family members to say, she can get you. She needs to get you because she needs to tell you, I'm angry and I need you to listen and I need you to understand who I am. But it's also very threatening. Uh-oh, who's going to take care of me? Who's going to be more capable to keep me safe? And it is a constant back and forth between this. Am I safe in your arms? Will you not let me get away with it? I need to get away with it because I need you to understand me. This had to feel frightening to her. Did she now doubt my trustworthiness? Was I no longer safe for her? Would our work together continue? I know that there would be emotional fallout if this interaction, as brief and nonverbal as it was left unaddressed. If that were not tackled, the entire then course of treatment and course of would be guided by that. We then create defenses. And we do that in life all the time. And sometimes it's good because, we need to be able to see and pick up on a situation, but and it may not be appropriate for there be a clarity, but oftentimes there is. Let me tell you, let me tell you, I'm sorry, I made a mistake. It changes the course of how the relationship goes, whatever the nature of the relationship. Again, patient-therapist, family patient, family therapist. One of the big issues for working with families is oftentimes they feel that I'm going to break up the family or make the kid, so angry at them that, it's about healing. It's about recovery. It's about safety. It's about that emotional language, which I'll talk about in a little bit. It's about creating the space where the negative emotion, the bad emotion, can be tolerated because that is seen as intimacy and closeness. It's about getting through that stage to reconnect, because not only then are the happy feelings good, but the bad and angry and down and so on feelings are also embraced and seen as normal. We are born with aggression. We are going to die with it. That's Freud, right? That we have these aggressive drives that we have to deal with throughout our life. Bowlby, we're born with attachment, right? We start out attached, right, by the umbilical cord. We die with loss. And how does a child begin to integrate that they can tolerate loss if they have never felt held? And why do families hold? And why do they sometimes hold? And why does loss become a boundary issue? Why is it that ultimately for some families it's the fear of loss that keeps them the helicopter parent? And how is that helpful for an eating disorder child or any child? And so all these things, these are the failures in attachment that somehow feel like, oh my gosh, it's parent blaming. It's not. It's things that we do all the time, every time. And if you have a child that's more predisposed to being having a sensitive character from wherever that comes, to be a perfectionist because they have an inheritable trait or because they've learned perfectionism, because they're really smart, and because life never makes sense on a one-plane basis, that everything is complicated, and they're in their head a lot, and they're trying to figure things out, or because they feel that the family, lives one way, and they are very different and live another from whatever that other may be. They're the round peg and the other way, the square peg in the round hole, and they don't quite fit. Those are attachment issues, and they're not terrible, and we ought not run from them. Those are the things that in helping families heal, to not be afraid of. Because in this case with Johanna, there were so many mistakes that I made, and given the beauty of her, because she was so provocative, it made it a ripe ground for the parents to see me engage and to say, I screwed up. You caught that. Let's talk about that. What did that mean for you? And where is it then the you and me together in terms of boundary setting? If you do that out in the world long enough, people are going to say enough with you, right? But your parents hang in there, but they hang in there with love, and they hang in there with frustration, and they hang in there with fear. And so how to get it to move beyond that so that that child can also take responsibility for the use of their behavior as a way to try and convey and express what they need to do emotionally. And teaching that language is a very, it sounds so easy, but put into actual theory, practical application is very hard. We talk about these things very, what did Freud say? Freud said, what's the purpose of a productive life? To love and work. Well, okay, all sounds good, right? But, why do we have so many problems? Why do we have so many problems if we say, attachment is good and we want to, be loved and feel close? Why do we defend against it? Why do we defend against intimacy? What are we afraid of? What is it that has been in our way that has kept us from feeling close and has kept us from feeling that sense of emotional safety and relaxation in the arms of whomever? Attachment issues don't stop in childhood, right? They continue through adulthood. They continue through our adult lives. And understanding an attachment pattern in terms of who we seek and why we seek, and then how to heal, because in those adult relationships too, they don't have to be perfect, they just have to be pure in their articulation, in the use of words, in the use of expression, in the use of using things to create and rebuild and repair. So we have the beauty of that in vivo and in a very controlled setting in a therapeutic session to help patients and families get to that place. The issue at hand between Johanna and me was trust. I felt I had breached it with my facial expression. She knew she had gotten to me. Would our work together continue? Was I no longer safe for her? I knew there would be emotional fallout if this interaction was left again unaddressed. When I met with Johanna, I started by asking how she felt about my reaction in the previous session. What reaction? She responded. Anna Freud, right? Okay, defenses already, denial, boom, Johanna, I said, I know you don't miss a trick. You tuned into everything that's said, in both words and behavior. I need to tell you that I made a mistake when I grimaced at you. I am sorry. Silence. I think I got caught up in your family's anger at you for not eating. I also think you were trying to provoke me by mimicking me. I never said that I felt frustrated by her. I didn't feel I needed to use that word. We both knew that she had been trying to push my buttons, and I took the bait. I knew what was underneath all this behavior, I told her. I also know that sometimes it's difficult for all of you, referring to our family, to tolerate. It takes time to understand it. It takes time to understand how to catch it before it happens. Remember, our work is about helping uncover the words and feelings underneath your behavior, especially the behavior that is provocative to your parents and destructive to yourself. Okay, so very chock full. Some of it I started to address during the case. But this is then what is before you, and this then becomes how to bring the family in to helping heal this, to helping the therapist be used as a role model and as a transferential figure, and as a guide and teacher to parents, how to help them to learn and to teach and learn this language at home. So what constitutes authentic relationships? Establishing safety. What is safety? The reliability that someone is going to be there without judgment and without criticism. Sounds so easy, right? You know, we screw up all the time because we're hurting, mostly because we're hurting. There are a percentage of the population who are mean-spirited and they look to harm because they are truly mean. Most people use criticisms because of a number of factors. They're hurting, they're feeling competitive, they feel less than. So again, there's always a motivation behind that. It is just too simplistic to say, oh, the person's critical. Well, where is it coming from? Rigorous honesty. One of the first things, again, going back to analytic treatment, this is what you learn. You lay on the couch 4 times a week. The only thing that the therapist asks of you, the analyst, is that you show up and that you have rigorous honesty. Okay, so how can that be brought into the treatment room? How can that be brought into parents to not feel afraid of the truth? Why does the truth feel so much more painful? Why do emotions feel so much more painful to reveal than having a symptom? Why is it easier to have an eating disorder than to feel and to express? We think it is so easy to, these concepts which are so general and like, duh, of course, but to put them, really live them, means that we are asking of ourselves to be that vulnerable. We are asking ourselves to be that vulnerable in a family that may have a lot of attachment issues. And there's a whole list of attachment styles that happen and problems that happen, from the child who feels criticized to the child who there was a divorce in the family. We have so many things that come at us. Why on earth would it make it safe for us to peel that away and expose what's really going on inside of us? And the world doesn't support, us feeling safe. So what is it in that very special? Because in the end, right, what do we have? We have our relationships and we have love. And the sanctity and closeness of those relationships are paramount, because what is it that ultimately is going to get us through when the going gets rough? Is a belief in ourselves and that in safety and infrastructure. And if that doesn't come initially growing up, or you don't feel safe for whatever reason, that you find ways then in later life, through therapy, through finding healthier relationships, to feel safe. These are the components that go into what is so beneficial to me that it's worth me not throwing up any longer. What is it that you got for me to make it safer? And so the beauty of working with families is that they are there because they want to be there, because they know, because they want to make changes. So when I say to patients, and there have been times where there have been families who no way, no how, we're going to accept any responsibility. And so then being with those patients alone, I say, you can and will still recover. You will come to understand the limitations of your family and hold it in a very different way. But when families are there and you've got the beauty of them wanting to work together, isn't that quintessentially, this is what we came from, families, and to create it in whatever way, in whatever structure that takes, biological or not biological, is the source of recovery. Emotional healing, emotional knowing how you feel emotionally, that infrastructure inside of you now that tells you that you are worthwhile and worth something. That's where the cultural stuff comes in and the social stuff comes in. 1 year you gotta be this way, another year, okay, so you fit into that way right now, but next year not going to. That falls away as to the motivation. Or if I, buy this for the motivation, all those things are good. We live in a culture that's like, oh, we've got all these things that we can do, and why not, right? Part of being human is pleasure, but pleasure is very different, right, than internal joy and internal peace and internal safety and relatedness. Therapy is about relationships. Empathy, what is empathy? Very easy to say, very difficult. The ability to put yourself in someone's shoes and experience what the world is like through their eyes. This is, simple example. Parent says, oh, I'm cold, put your jacket on. The kid says, I'm not cold. Says, it's cold outside, put the jacket on, right? That's a very simple form, say, oh, well, she's not cold. Okay, well, she's not experiencing the world as cold, so leave the jacket off, right? boundaries have to come in if the kid's going out, like Johanna's got, 20 degrees and she's wearing, shorts and a t-shirt. Moving beyond the judgment and blame, everybody has a role in this. If you want to use it, harshly, everybody is to be judged and blamed. Everybody's at fault, or everybody can take responsibility for what it is that they may have contributed. And then creating the space for trust to develop. Me being able to say I screwed up establishes trust. Parents being able to say we didn't know establishes trust. Child being able to say, yes, that was provocative to you. I know what I was doing. Establishes trust. Reliability. And reliability means repetition over time. A language of emotions. Developing a language of emotions means, think about a toddler, right? Learning language, regular language, your language of origin. Kid comes, oh, give me your cup. That's a cup. That's a cup. Give me your cup. Finally, the kid associates, oh, cup, starts saying cup. Why we expect children to know how they feel without us helping them learn the language of how they feel. The kid's stomping up and down. Mommy says, daddy says, no more juice. You got to eat your done meal. The kid starts going up and down. What does the parent need to do there? Just like identifying the cup, you're identifying the feeling. I know you are angry. And to give a label so that emotion becomes safe in which to feel and in which to tolerate, that there's nothing wrong with it. Nothing needs to be done about it, versus don't be angry or don't behave that way. It's okay, I get you're angry, and you're still not getting any more juice till you eat your meal or whatever you eat, Creating healthy boundaries, very tricky one, because when is it okay to say enough? Curfew, you're home, you're not home, you can't go out for the next week, whatever. Versus the most important and significant ones are where families try to make everything okay, and you cannot. So the one that I use in my book is about sexual boundaries, right? Parents know, for the most part, unless of course there's trauma in the family, or abuse, trauma abuse, you don't touch your children, right? You just don't, and between cleaning a diaper versus inappropriate touch. That we have down for most of cultures, right? But what about when parents think, oh, we want our kid to be really sexually comfortable, so the parents walk around naked? They dismiss and ignore. There's the empathy part. What is it that what is this like for my child, who's a developing sexual creature, to be possibly stimulated by the parent? What is the message, right? Because kids should be stimulated by everything. The moment we figure out our genitals, we're on it until we're told, like, okay, that's okay, but you have to do that in private, right? So there's so much sexual stimulation, and to then put it in front of our child, that's a boundary issue. To have parents who just open their kid's bedroom door, boom, or just knock and then open the door, rather than knock and say, hello, can I come in? And of course, if this is an urgent situation, you need to get in there, and wait for that child to say, okay, it's okay to come in. Those are boundary issues that affect stability and affect trust and affect safety and make a child feel bad. Why can't I, or I'm saying no when I should be saying yes, and it disrupts. The parents who say, you should not feel that way, or don't feel that way, there's no reason to feel that way, that child learns to discount that internal voice and stops listening. Oh, so that immediate nanosecond, if I know how I feel, suddenly becomes, well, maybe I feel this way. Or the manipulation piece. Oh, I see. She needs me to feel that way. I'm going to start saying this is how I feel and this is what my truth is. Creating healthy attachments throughout life. This is, what I talked about earlier in terms of how these things repeat themselves. And then living in the balance. What does that really mean? It means living with ambivalence. That oftentimes we never feel one way about anything or anyone or any situation. And to accept that, to take away the black and white thinking that it can be this and this, simultaneously, and to accept that as not as disingenuous, but rather quite authentic. Those are the emotional language. The more you understand it inside yourself, the more you are able to step outside of it, no matter what the condition is of the other person, and embrace them in a way that they feel held.
Anything else you'd like to say in closing?
This has been awesome. I have never been with a mixed group like this, and so you really just proved to me, yeah, this is what this is really easy to do. It is all the same language. 5-cent words are generally better than $5 words. Although sometimes $5 words really you say it and it's like it means all these things. But most times, we're all on the same page. We're all doing this together. And thank you for giving me this opportunity.